Sitting beside a hospital bed, watching that slow, steady drip, you feel entirely powerless to help someone you love. To deliver life-saving treatments through an IV, medical professionals must forcefully punch through the human body's ultimate security system, the skin. Piercing that armor creates a direct, unprotected pathway. It introduces an immediate vulnerability that exposes the body to a specific progression of medical complications. These risks travel a distinct spatial path. They begin as localized damage right at the puncture site, but if left unchecked, they can spread throughout the entire bloodstream. Understanding the physical path of an IV provides the specific knowledge needed to monitor a patient's safety in real time. The moment the needle breaches the tissue, the body reacts. Depending on the medication, the patient may feel harsh burning, stinging, or deep muscle soreness right at the injection site. In this skin cross-section, unstopped bleeding collects beneath dermal layers, forming a bruised hematoma. If medication leaks out of the vessel, it floods surrounding tissue, called extravasation. This triggers severe inflammation. Cells shrivel and die, causing permanent scarring known as necrosis. The physical placement of the needle also introduces mechanical errors. Choosing the wrong injection site or inserting the needle too deeply can cause the metal tip to strike and damage underlying nerves. A struck nerve misfires, leaving the patient with chronic pain, lingering numbness, or in severe cases, localized paralysis. Even a perfectly placed needle is dangerous if the skin wasn't cleaned properly. Poor aseptic technique drags surface bacteria down into the puncture wound, breeding localized infections like cellulitis or painful swollen abscesses. Surface-level tissue damage and localized pain are aggressive and destructive, but they are only the earliest warning signs before the danger finds its way into the main vascular highway. Moving deeper past the surrounding muscle and skin cells, we reach the interior of the target vein itself, which is now receiving the foreign fluid. In this longitudinal view, the plastic catheter rubs against the tissue. This friction inflames the inner walls, causing red swelling known as phlebitis. This triggers a defensive response, building a jagged blood clot, a thrombus, that catches cells and blocks the vein. The line itself can also fail mechanically. The needle or catheter might become totally blocked, an occlusion, or it can physically dislodge from the vein, causing infiltration. When an occlusion blocks the line, the danger is immediate, not because of tissue damage, but because the patient suddenly stops receiving their critical, life-saving medication. These vascular complications weaponize the vein against the patient. The delivery mechanism becomes a hazardous choke point before treatment reaches the rest of the body. Once the fluid successfully mixes with the rushing bloodstream, the dynamic changes entirely. A localized issue expands into a total body event. Earlier, surface bacteria caused localized abscesses, but if contaminated equipment pumps bacteria directly into the blood, that infection is delivered to every organ simultaneously. This aggressive systemic spread triggers sepsis, an overwhelming immune response that causes multiple organs to rapidly shut down. The chemicals themselves can also overwhelm the system. Incorrectly calculated dosages or infusion rates that run too fast disrupt the body's delicate internal equilibrium. Administering a rapid IV dose of potassium, for instance, violently spikes the blood's chemical levels, triggering a severe electrolyte imbalance called hyperkalemia that can induce cardiac arrest. Sometimes the danger is an inherent biological incompatibility. The body detects the foreign chemical components of the medication and mounts a sudden, aggressive allergic reaction to reject them. In severe cases, this rapidly escalates into anaphylaxis, a life-threatening total system shutdown that requires immediate, aggressive medical resuscitation. Once a complication enters the systemic phase, the margin for error vanishes. At this stage, a routine therapy session can escalate into a critical medical emergency. Pulling back from the internal biological chaos, we return to the quiet reality of the hospital room. Safely managing these powerful treatments relies on dedicated human observation. You can actively monitor for the physical warning signs. Watch for unexpected swelling near the tape, sudden skin rashes appearing on the arm, or a drip chamber rate that visibly speeds up. Recognizing these specific complications removes the uncertainty of a hospital stay. knowledge applied at the bedside is a patient's best defense.